welcome back to my channel, guys. So this is gonna be the very big lecture or very big video because this is about ameloblastoma and I've covered everything possible from J1st. So this is going to be a huge video. So let's start. What is ameloblastoma? We are going to see in the definition. It is a true neoplasm of enamel organ which does not undergo differentiation to the point of enamel formation. So it is a true neoplasm of an enamel organ. So it's in neoplasm of enamel organ which does not undergo. It does not lays down enamel. Okay, this is the definition. But there was a definition given by Robinson in 1937 which you have to remember, which says it is a unique tumor that is unicentric, it is a benign tumor that is unicentric, non-functional, intermittent in growth, and it is anatomically benign and clinically present. So you have to have this 5 points in your definition. It is a unicentric benign, that will be there, benign tumor that is unicentric, non-functional, intermittent in growth, anatomically benign and clinically present. So there is a mnemonic unique UNIAC by which you can remember this definition. Unicentric, non-functional, intermittent, anatomically benign, and is clinically present. Now we come to the synonyms. It is also, ameloblastoma is also known as admentinoma, admentoblastoma, and multilocular cyst. Admentinoma, admentoblastoma, and multilocular cyst. These are the three synonyms you all have to remember if you are writing a long note or a short note. So it is the second most common neoplasm after odontoma, also in India. So after odontoma, it is second. Now classification of it is given by WHO 2022. It was based on clinical types. Ameloblastoma, unicystic is the first. This is a newest classification. Before classification was 3. But this is what you have to follow now because it was given by WHO. So ameloblastoma unicystic, ameloblastoma extraosseous or peripheral, ameloblastoma conventional, and adenoid ameloblastoma, and metastasizing ameloblastoma. Now we will learn about some in detail, while some we will just have a overlook because they are not studied in detail. This classification is given in 2022 itself. So here I have made a differentiation box, or rather a box which gives the characteristics of each. So let's start. Ameloblastoma unicystic. This we are going to learn in more detail as well, but I have to just put it in your head. It's one of the class. And this is based on the clinical types. Second decade, it occurs during the second decade, just in between your 20s and 30s. It has slightly male predilection, and it is posterior mandible and ramus which is most affected in this. Ameloblastoma unicystic. There is single cyst of ameloblastoma with epithelial lining. Single cyst there is, and it has epithelial lining. It does not have multiple cysts. So you can see, can you appreciate in this photo? Outside you will not understand it's unicystic or not. Once you take a radiograph, you will notice this thing. Can you appreciate this? Can you appreciate this cyst? And if I see of its histology, I have placed the histology of unicystic later once we are learning about it in detail. Now we come to the second type. One is unicystic, next is Extraosseous. What do you mean by extraosseous? Other than the bone, it will be the gingiva or the tongue, the mucosa. So extraosseous, it occurs during the third and the fifth decade, and it has also slightly male predilection. It occurs in the soft tissues of mandibular, premolar and maxillary molar region. So mandibular premolar region, the labial, the buccal mucosa, or the more in mandibular it occurs in the premolar than in maxillary molar regions. The other side is gingiva or the edentulous alveolar pore. It can occur in the gingiva. Okay, no intraosseous component. It does not go and penetrate the bone or does not erode the surrounding bone. Okay. Its histopathology is just like the conventional ameloblastoma, and its size is about 3 to 2 centimeter. We'll learn about conventional and we'll see how its size is. But this one is just 3 to 2 centimeter. Can you appreciate this? Swelling out here in the alveolar mucosa. This is how it looks. It will be looking as conventional. I will tell you more about conventional. I have not spoken about conventional. So these are the two types. Unicystic is done, then is extraosseous. Now we come to the conventional, which we are talking about. We will learn about this one in detail. So ameloblastoma conventional, 4th to 5th decade it occurs. No gender predilection, male equal to female. Post-molar of mandible. So mandibular posterior molars are more affected in this. So what is the histology? Islands or strands of odontogenic epithelium bounded by cuboidal or columnar cells with palisaded hyperchromatic nuclei. So you will have islands or strands of odontogenic epithelium bounded by cuboidal or columnar cells, which will be the ameloblast, which will have a palisaded nuclei, hyperchromatic that too. And reverse polarity will be occurring, that is the nuclei will change its position. Loose central epithelium will be there with stellate reticulum, with very loosely bound stellate reticulum inside of the strands. Next we come to adenoid ameloblastoma. This is the newest, so nothing more, lot is not studied about it, so we'll just go through it. Ameloblastoma, it is 4th decade it starts appearing in life. Slightly male predilection, no site predilection can occur anywhere. Ameloblastoma like component, duct like structures. So it has ameloblastoma component plus it has duct like structures, and there are walls and morules. Cubiform architecture is seen in this. It is kind of like adenoid odontogenic, where you will see walls and ducts, but at the same time it has its ameloblastic epithelium. So it is adenoid ameloblastoma. Last one is metastasizing. We are going to learn about it. I have written the occurrence rate also over here. 91% is in ameloblastoma conventional, 6% is unicystic ameloblastoma, 2% is extraosseous ameloblastoma, and 1% is metastasizing ameloblastoma, which we are going to learn now. So the mean age of this is 45 years. It has slightly male predilection. If you are a male, be careful. Primary tumor site is the mandible. Mandible is more affected, and the metastatic part of it can be the lung, the lymph node, and also the extragnathic bones. Not written here, but I have written somewhere down there. And both primary and metastasizing tumor shows benign conventional ameloblastic, which we are going to learn the histopathology of the benign conventional. No cytological atypia or difference is seen featuring of malignancy. Nothing like that. It is seen, the histopath is just like benign, but it's just metastasizing. So these were the different classification. I will show you the photos of conventional now. Conventional, you will see a very large swelling in the facial area, and you will have here, as I told you, you will have strands or islands of cells with cuboidal or columnar epithelium, which has hyperchromatic nuclei which are palisaded, as well as they are polarized. So this is follicular and this is plexiform, I think. Wait, let me see. Yes. We'll learn about what is follicular and what is plexiform, okay, and they are beneath, and then I'll explain what each one is as well. So here you will see multilocular. Can you see the multilocular swelling? So that is about conventional. We are learning about conventional. We'll learn about conventional more deeply as we go further, so don't worry. Then there is another one which is there in the book. I don't think a question can be asked. It is important in MCQ point of view or Viva point of view. So pituitary ameloblastoma, which is also known as craniopharyngioma or rat case pouch tumor. So it is a neoplasm which involves the CNS, the head. Most common tumor of childhood. It is found in childhood and adolescents, not in old people and adults. So though originate from the craniopharyngeal duct derived from rat case pouch, so it originates from the craniopharyngeal duct, which is derived from the rat case pouch. The cell rests have pluripotent and on occasion give rise to tumor similar to similar to ameloblastoma. Okay, so what happens is the cell rests which are there, they are pluripotent. What do you mean by pluripotent? That they can transform into other cells. So on occasion they give rise to ameloblastoma like tumors in the CNS. So clinical features in this is endocrine disturbances. You will have different endocrine, because pituitary is the one to control the endocrine. So you might have endocrine disturbances. You will have drowsiness. So you will have tiredness, drowsiness. You cannot do your work at your own pace. Something with toxic symptoms, other toxic symptoms you will have depending on its location. So you will have, this will depend where it is placed, which center with that pituitary is controlling is getting affected. Then we have histopathology, that is irregular calcified masses with occasionally foci of metaplastic bone or cartilage. So there will be calcified masses also present in between the tumor with occasional foci. The foci means that from that it originates metastatic bone, and there will be calcification around it or cartilage. So presence of islands and nests of ghost cell calcification and cyst formation similar to COC, calcifying odontogenic tumor. So as we saw in CEOT, that two calcification residing rings were there, right? Similarly, the histopathology here shows the ghost cells as well as the lessiging rings. So craniopharyngioma with tooth formation reported. Sometimes tooth can also be formed in these areas into the pituitary. This was about pituitary ameloblastoma. We don't need to go to the detail because we are talking about the ameloblastoma in the jaw. So let's go for the pathogenesis, how it is caused. So the stimulus is still unknown, but there are some theories, schools of thought, that the tumor may be derived from cell rest of the dental organ cell rest, either remnants of the dental lamina, that is cell rest of serrae, or the dental remnants of the HERS, that is molasses, cell rest of molasses. So either that could be the cause, remnants of dental organ, or it can be epithelium of the odontogenic cyst. So there is an odontogenic cyst, the epithelium remains and it transforms into ameloblastoma, particularly dentigerous cyst. Okay, it could be. It is a theory. Now there is another theory which is disturbances in the developing of enamel organ. There are some disturbances in this occurs. The enamel organ transports to somewhere else and starts growing over there. So this could be a possibility. This is a theory. Fourth theory is basal cell of surface epithelium of jaws. The basal cells of the surface epithelium of jaw can proliferate and become into ameloblastoma. These are all the theories. But at present, it is thought that it is some mutation in signaling pathways. There is some mutational defect through which this occurs. So it is active. What are the mutation? It is MAPK and hedgehog. NAPK and hedgehog is a pathway during stratum intermedium. I had told you about this in previous videos. MAPK and hedgehog, these are active during tooth development. So any mutation in the cell programmed for tooth development. So it is said that it is written in Schaeffer's that mandible BRAF V600E mutation occurs in mandible for ameloblast to occur in the mandible, and for maxilla it is SMO mutation. Let me repeat again so that it goes in your head. Mandible BRAF V600E. BRAF V600E mutation, and in maxilla SMO mutation. Remember this, so if it comes in question you can write the mutation. So environmental factors and individual patient variables such as general health status, nutritional status can also be the cause of this disease, likely to have a role in modulating the incidence of disease. Now we come to the clinical features, how you can see it clinically. Occur between age of 10 to 90. I have told you all the decades, all kinds of ameloblastoma occurs. So that way you will have to diagnose. So you see a swelling in mandible over here. So 30 to 39 is the mean age that this gets diagnosed. Okay. Where I went? 1 minute. Okay. Next, we go further. The mean incidence at 34.5 years. So the mean presentation of this defect of this ameloblastoma is during 34.5 years. 10% arise in children. No sex predilection. Slow growing. It is painless. Bone hard swelling. If it's on bone, then it's a hard swelling. So these are the clinical features you have to remember. No sex predilection, so it is male equal to female. As I have told you, in conventional it is male equal to, this is conventional only, which we are learning. Slow growing it is. Painless it is at the start, can become painless one. Pain can be then become painful one. The nerves and all are involved. But during growing it is painless. It is hard swelling when it's on bone. Then the facial asymmetry could be there, as we saw in the classical one. I'll show you again. Large lesions can cause mobile teeth and pain and paresthesia. As I told you, it will grow. If it grows in the bone, then the teeth can move. Then it can be locally invasive as well. Can affect the other areas around it. Can infiltrate medullary spaces, causing erosion of cortical bone. It can get into the medullary spaces, and the spaces in the cortical bone can also get eroded. So as I told you, areas of jaws which are most affected: mandible, most common BRAF gene, I have just told you about this. In maxilla, variable in maxilla, the SMO mutation. In the mandible, the molar ramus angle is 3 times more than the anterior region and the premolar region affected. The molar ramus angle, this angle is more affected, than 3 times more affected than the premolar and the anterior region. And in the maxilla, it is variable. So here is a picture also, but I don't think you have to go in such detail. So we'll go forward. Ameloblastoma is the different sites in racial groups. So in different races, it is different sites in different racial groups. In Asians, few tumors involving the ramus than do whites and blacks. So in Asians, there are less tumors which involve the ramus, but in whites and black they are more common. Blacks increased frequency of tumor in anterior mandibular region. In the blacks, there is anterior mandibular region more common than the ramus. Radiographic features about this: it is multilocular cyst-like lesion. It is multilocular cyst. We have learned about it in the synonym. It is also known as multilocular cyst. Exhibits soap bubble experience. Here you can see the honeycomb appearance. You will see the soap bubble, like this soap bubble experience. You can see appearance. A tumor compartment appearance with septae of bone extending into the radiolucent tumor mass periphery of lesion. So there will be a tumor compartment appearance. It appears as compartments. There are septae which extend into the radiolucent tumor mass periphery of the lesion. It is not unilocular. It is also known as multilocular cyst. Smooth of and thinning of the cortical plates in the jaws. These are the cortical planes. There, from the anterior posterior, there will be smoothing and thick. In the unicystic, I have put it in the photo. So here you can see that there is radio. Here also you can see a soap bubble or honeycomb pattern. Soap bubble, I'll show you. Periphery of the lesion is smooth and thinning of cortical area. This happens in expanding or advanced lesion. Then there is desmoplastic ameloblastoma. This is one kind which we are going to learn about in the histological types. In this, there is mixed, there is areas of opacity and lucency, and they mimic fibro-osseous lesions. So desmoplastic ameloblastoma, its its radiological features mimic fibro-osseous. So if you want to write a DD, that is differential diagnosis based on radiographical region, then desmoplastic ameloblastoma can be confused with fibro-osseous lesion. Here you will have there's a soap bubble appearance, large locules, then there is multilocular honeycomb appearance, and there is unilocular. This you can see in unicystic. Now we come to the histological features of the. So the conventional type we are learning, let me take clear. We are learning the conventional type because it occurs 91% of the time. So in conventional, there are these 6 histologically different entities which you are going to learn. Not entities, they are patterns. There is one follicular, there is plexiform, there is acanthomatous, there is basal cell ameloblastoma, there is granular cell ameloblastoma, and there is desmoplastic ameloblastoma. At follicular, it has 29.5% recurrence rate, can reoccur once it has been enucleated and excised out, can reoccur. So it is very common. Very discrete islands of the peripheral layer of cuboidal or columnar cells So it is very common. This kind of follicular is very common. So what it has is very discrete islands of a peripheral layer. There is a peripheral layer of cuboidal or columnar cells. Nuclei are well polarized and cells resemble ameloblasts or pre-ameloblasts. And they enclose a central mass of polyhedral, loosely arranged cells resembling sterate reticulum. So let me tell you again, there are islands. There are islands of discrete islands which have peripheral cuboidal epithelium of cuboidal cells which resemble ameloblast or pre-ameloblast, and their nuclei are hyperchromatic and as well as well polarized. They enclose a central cavity which consists of sterate reticulum resembling cells, loosely arranged cells which resemble sterate reticulum. Occasionally, keratin pearl may be observed. Occasionally, not a common finding. More common finding of keratin pearl is in acanthomatous, which we are going to learn. So can you appreciate this diagram? This diagram shows you that there is these discrete islands which have a peripheral cuboidal or columnar cell epithelium which resembles ameloblast-like cells or pre-ameloblast-like cells. In between, there are loosely arranged cells which resemble sterate reticulum. This one. These peripheral cells are tall columnar or cuboidal with hyperchromatism, and as well as it is polarized. Can you see? It is near the lumen. The nuclei is near the lumen. So this is about follicular. Now here you can see it is a magnified high power. Can you see the nuclei which are nuclei of the basal peripheral cells and the sterate reticulum in here? Can you appreciate this one is another? So can you see these islands of strands with peripheral cuboidal or columnar epithelium which has hyperchromatism. As well, you can see here the sterate reticulum which is loosely arranged. So this was about follicular. You have to remember all the points which I have given you. Next we go to the plexiform. It has 16.5 recurrence rate. So once it is removed, in 16.5% cases it can reoccur is what it is saying. So ameloblast-like tumor cells are arranged in irregular masses. They are arranged in irregular masses. Network of interconnecting strands. In a network of interconnecting strands or masses. Each of these strands is bound by a layer or double of the columnar cells. So there you saw islands. Here you will say irregular masses which are arranged in a interconnecting strands. Network of interconnecting strands you will see. Now, each of these strands of masses is bound by a layer or double layer, same as that of columnar cells. Sterate reticulum may be present or not. Less prominent than the follicular. So here it is compressed. So the sterate reticulum may or may not be visible, but it's not that prominent as you saw in follicular. In areas of cystic degeneration of the stoma, which was there also, but here there will be more. So can you see the interlacing pattern? Anastomosing cords are available, and you will have peripheral cuboidal, a single layer or a double layer may be present. Sterate reticulum cells may or may not be appreciated depending on the degeneration. So here is a photo. So this was follicular and this is plexiform. Can you see the islands are more prominent, the sterate reticulum are more prominent, and here it is kind of interlacing and not that prominent. There is cystic degeneration. We can appreciate the cystic degeneration, and here are the intermosine cords which go, and they have a peripheral, cuboidal or columnar cells with hyperchromatism and polarization, and the stellate reticulum may not be appreciated that well in this picture or in this variant of histopathology also. Next is acanthomatous. In acanthomatous, it is 4.5 recurrence rate. So once it is removed, 4.5% it can reoccur. So here what happens is the stellate reticulum, that is the inside part, the lumen, inside the lumen. This is the periphery, you see it everywhere. The inside part, stellate reticulum, gets squamous metaplasia. So it gets converted into squamous cells, and sometimes squamous, sometimes with keratin formation in central axis. So the squamous cells, they produce keratin. They are present in the epithelium, they produce keratin. Skin epithelium, here they produce epithelium. So present as hybrid, this is later. So remember, in acanthomatous you will see keratin pearl, then you will say this is acanthomatous. Here you will see, I will show you a photo of it. So it is written in Schaeffer. Sometimes it is present as hybrid, that it can be have other features like follicular or plexiform plus desmoplastic pattern. It will be a hybrid ameloblastoma. Sorry. So here you will have squamous metaplasia of the cells, of which cells, stellate reticulum cells, and you will have keratin formation. Can you appreciate this keratin? Acanthomatous pattern. Here also. Here also. I will show you. Yeah. So the two pictures I had about. Next we have basal cell ameloblastoma, which is the rarest among all of them. Right. So the occurrence of it is quite not common because it's very rare. Resembles basal cell carcinoma of the skin. It resembles the basal cell carcinoma of the skin, as we have same little bit differences. Epithelial tumor, it is in the face. Epithelial tumor cells are more primitive here. The tumor cells are primitive and less columnar, as we saw in others, and generally are arranged in sheets. So they are primitive, less columnar, and they are arranged in sheets. There is a photo of it, but I don't have so there are, you can see the sheetly arranged pattern. It is less primitive. This is a very rare variant which you will get. I don't have a picture which will show it. This is the only one picture I have of basal cell. Next we come to granular cell. This is also rare, ameloblastoma. This is coarse granular in the stellate reticulum, have coarse granular eosinophilic, often includes periphery of the columnar cell. So there is periphery with columnar cells, and the stellate reticulum has coarse granular structures, often includes the ultrastructure. If you go to see the ultrastructure, granular represent lysosomal aggregates with no cellular components. So it has granular, these granules represent the lysosomal components, aggregates with no cellular component. There are no cells involved in it. So how do you think this happens? How do the lysosomes are involved in this stellate reticulum? It may be dysfunction in the lysosomal enzyme or the lysosome associated protein involved in enzyme. The targeting lysobiogenesis, the enzyme which targets lysosome biogenesis, or defect leads to accumulation of the substrate that would normally be degraded in endosome lysosome system. So there is accumulation of lysosome which would have been normally degraded, but it is there due to the enzyme dysfunction of the lysosome, the protein which is related to the enzyme in the lysosome biogenesis. Okay. So it is that the substrate, all of the substrates that would have normally be degraded in a normal endosome lysosome system are getting aggregated. That is it, and you have granular ameloblastoma. Next, you have cytoplasmic granularity due to increased apoptic cell death in the neoplasmic cells. So this cells, neoplastic cells, they have increased apoptic cell death. So they have their own cell death, followed by phagocytosis of these cells by neighboring neoplastic cells. Once they are dead, the other cells come and they phagocytose, and the remnants of these cells are inside the neighboring neoplastic cells. So granular cells is a transitional or mature phase. So from the stereo reticulum, you will have granular degeneration which can lead to cystic areas. So it is said that it is a transition. This stage is a transition. Granular cell ameloblastoma appears to be aggressive lesion with marked proactivity. So it is marked to be an aggressive region because there is this constant lysosomal and cell death granules present. So for occurrence, unless appropriate surgical, so it has to be removed because it's very aggressive. For occurrence, unless appropriate surgical, so you have to do end block over here, right? We'll learn about what is end block, what is curettage, what is resection also further in the slides. Measures are interstitial at the first operation. So for occurrence, for reoccurrence, it can become a problem unless appropriate surgical measures are instituted at the first operation, because it's very aggressive and proactive. When we come to the last histological part, it is desmoplastic ameloblastoma. In desmoplastic, it is rarely encountered, consists of dense collagenous stroma. It has rarely encountered, so not that widely, not that common. It consists of dense collagenous stroma that may appear hyalinized or hypocellular. It can be hyalinized or hypocellular, the collagenous stroma. Epithelium to be squeezed and fragmented by the dense stroma. So the epithelium is squeezed and they can be fragmented by the dense stroma and has a greater tendency to grow in the strands and cords of epithelium like the plexiform. So it has kite tail appearance, and large tumor islands may appear irregular with a stellate appearance and occasional exhibit bizarre pattern with typical animal-like configuration. What I'm going to say is it has similar properties like plexiform and follicular, but the only thing is the epithelium is squeezed together, the stoma is less also squeezed together, and then there is kite tail appearance. Then these large tumor islands are also squeezed together and they appear to be some animal shaped configuration or some bizarre shape. Central cells are often scant in the epithelium proliferation. The central cells in the lumen are very scanty, and the peripheral cells of strands and cords are flattened or cuboidal. Now as we saw, it could be cuboidal or the columnar, the ameloblastic periphery, but in this one it could be flattened or it could be cuboidal. Then there is reverse polarity of nuclei, subnuclear vacuole formation. Now let me show you how the granular cell and the desmoplastic ameloblast appearance. This is a basal cell variant which I showed you. This is a granular cell variant. So you will see granular cells cuboidal to rounded inside the ciliate reticulum, which is ciliate reticulum will have become rounded, and you have granular cells inside it. Granules resemble lysosome ultrastructurally. Okay, this is granular cell pattern. Now we come to ameloblastoma. Let's see the actual photo. So can you appreciate all of these granular cells? This is the periphery with the one or two layers, and here you have the ciliate reticulum which has become rounded, and there are granules present in it, and in between there is nuclei of these ciliate reticulum. Granules appear lysosome ultrastructurally, remember. Then we come to the desmoplastic variant, kite-like appearance. As we said, can you appreciate this? All of it is squeezed together, and there is kite-like appearance, but you can see the periphery of the cells. These are the peripheral cells, and they have hyperchromatism and basal. They have polarity and hyperchromatism, and they have subnuclear. Vacuolization not appreciated in this, so let me show you in this. Yes, densely fibrous stroma is also present. Densely fibrous stroma. Islands less conspicuous, very squeezed in. There are thin cords of epithelium. The densely fibrous stroma, they squeeze the islands. The central cells are a spindle shaped to squamated. The central cells become spindle shaped to squamated in these desmoplastic variant. So you can get a short note on either granular cell or desmoplastic. You have to write all of these points as well. Draw this diagram. This one with HNE pencil, and for desmoplastic this diagram. Now we are done. Okay, there is hybrid ameloblastoma which exhibit microscopic variant together with areas of follicular plexiform with desmoplastic and or stromal connective may be present at matured state. What I am saying it is a mixture of all these follicular plexiform, you can see. Now we come to the other variants which are not that important, but it can be asked in the MCQ or in the Viva. Other variants is hemangiomatous ameloblastoma, which is again less common. Common tissue stroma, connective tissue stroma has lot of blood filled spaces. The connective tissue stroma has a lot of blood filled spaces in hemangiomatous ameloblastoma. Large epithelium line capillaries. So there are a lot of blood filled spaces with the large endothelium line capillaries. Okay, you have to remember blood filled spaces. There are spaces which are filled with blood. Blood in between the histopathology when you see. Okay, and there are endothelial line capillaries. Theories of its cause is during angiogenesis, during the capillary formation, hematomatous malformation. It could be normal growth in a different, not a normal site. It can be trauma due to some injury. And there is blood vessels started to rupture over there, and there is separate neoplasm could be a different or a collision tumor, that two tumors collide together. Then we come to keratoameloblastoma. Histologically heterogeneous group of ameloblastoma characterized by considerate amount of keratin. So it is characterized by considerate amount of keratin. Now, histological 4 subtypes, not that important, just reading. Papilliferous, that it will have papilliferous like this type. Simple type is simple like normal, and there is simple with OKC, that is odontogenic keratogenic cyst, and there is complex histology. These are the 4 subtypes. If we talk about the papilliferous, this is rare, slow growing, and it's benign odontogenic neoplasm of epithelial origin. I'm going fast in this because not that important. So it is rare, slow growing, benign odontogenic neoplasm of epithelial origin. We are doing epithelial origin only. Locally invasive and non-encapsulated. Papilliferous is non-encapsulated, so it is locally invasive. Mean age to occur is 40 years. Male predilation is there. Male is more than females. Posterior mandible is more affected. Multilocular radiolucency, as we see in ameloblastoma, sometimes unilocular loss of intracellular adhesion. There is intracellular adhesion loss. So there will in surface layers desquamation, and there will be desquamation and necrosis separate from remaining epithelium. Pseudopapillary structures, as I told you, are projecting into the cystic lumen. Will be seen in papillary projection. So this was about the keratoameloblastoma and its 4 types. Now these are some points to remember, which I am just going to read because I have repeated it. So a few lesions are found to be compared to purely one histological subtype. Combinations are observed. I have said it, combinations are there. Histological subtypes may be prognostic implication for recurrence. So once you have a histological subtype, then you might have the recurrence. As I told you, the follicular recurrence rate is 29.5, acanthomatous is 4.5, plexiform is 16.5, and desmoplastic with the range of 4.5 to 29.5. These are the recurrence rate. So once you have found that this is a subtype, then you can see how much recurrence or how should be your treatment so that the recurrence will not occur. Stoma. So moderately or densely collagenous connective tissue, stoma epithelial component, proliferates in discontinued strands, islands, cords of in varying sizes. I told you before. A prominent budding growth pattern is seen with small round extension, capitulating various stages of enamel organ formation. So there is the prominent budding growth pattern which is seen, which resembles the enamel organ formation. So it is similar to how the enamel organ forms for a tooth powder. Now we come for focally in many ameloblasts. This is can be asked as a in viva. Proliferating epithelium. It is seen to exert an inductive effect on the surrounding epithelium. Once the ameloblasts are growing, they are sending the inductive effect on the surrounding connective tissue, and in these areas a zone of hyalinization of collagen is present immediately adjacent to the epithelium. So fibroblasts are almost not absent in these. The theory is, so why do you think a hyalinization is present just beneath the epithelium? So the theory is these are sending the inductive effect to the connective tissue to convert into odontoblast and later dentin, but they do not get the similar inductive effect back. So there is formation of hyalinization, but it is not mineralized. These hyalinization could be early dentin, could be they are trying to form enamel, but they are not getting the feedback. That's why they cannot, and therefore hyaline zone most likely represent the end result of this blockade in normal embryogenic sequence of odontogenesis. So the hyalinization is the end result, because you are not getting any odontoblast form. Now there is this Vicker-Gollins class. It says that something to be a neoplasm. These are the these are the most important qualities it should have. It is hyperchromatism of the basal cell nuclei. The basal cell nuclei should be hyperchromatized. The palisading with polarizing of basal cells. It should be palisading and polarizing nuclei of the basal cell. And the cytoplasmic vacuolization with intercellular spacing of the lining. So can you see here vacuolization is there over here, there is space. And there is hyperchromatic nuclei, there is reverse polarity, and this is all happening in the basal membrane, basal cells. Cytoplasmic vacuolization with intercellular spacing of the lining epithelium are manifestation of an impending neoplasm. This is what happens in an impending neoplasm, is what he say. Who is he? Vicker and Collins. So if this is asked, you write Collins. Remember, hyperchromatization, basal cell polarity, subvacuolization. Okay. Next we come to unicystic ameloblastoma. I think this is going to be a long lecture, so I will continue with unicystic and the tumor and the treatment in the next video. So thank you for a patient hearing. Okay, bye bye.